All right, this one is going to be a quicker lecture, kind of giving a framework for hematuria. So I want to do more lectures like this where I kind of go through a case and we kind of walk through each step of the case and how you can build a framework to really think about, okay, what kind of history, physical exam, labs, imaging I need to think through relatively common chief complaints or lab abnormalities, things along those lines. So in this one, we're going to talk about a case of hematuria. All right. So we'll do everything for hematuria. Okay, so let's develop our clinical reasoning here. So you're the attending hospitalist on call, and you receive a call from the ED to come and evaluate a 62-year-old male with a history of hyperlipidemia, well controlled on atorvastatin, and he's presenting with blood in his urine for the last 3 days. So right off the bat, right, blood in his urine for the last 3 days, that's hematuria, right? We can define hematuria, which we will in a second, right? But like once you hear that chief complaint, you should immediately be going down the hematuria pathway, right? There is some nuance to this, right? And I'll talk about why there's nuance to this. But the key thing is like when you get a call from the emergency department or the triage nurse, or you go start to the patient, they might tell you multiple different things, right? Like this patient came in, he's got blood in his urine, he's got abdominal pain, he's got chest pain, whatever. You as a physician need to decide what is the chief complaint and then run with it, right? And so that might take you actually talking to the patient and deciding, hey, they keep coming back to this one problem. This is the problem I'm going to run with. Or you simply ask the patient of everything that's going on, like what is the most concerning, right? And then you can kind of build your framework off of that. Um, all right, so this guy has hematuria. What is hematuria? It's the presence of red blood cells in the urine, right? Simple as that. It can be macroscopic or it can be microscopic, right? When it's microscopic, we tend to call it microscopic when there's at least 2 or 3 red blood cells per high power field on 2 or 3 separate urinalysis. Now, it should be the nuance I was discussing is there are other things that can cause your urine to look darker, okay, that aren't necessarily blood or red blood cells in your urine. Common examples would be hemoglobinuria, myoglobinuria, indirect bilirubin, porphyrias, and then certain medications like rifampin. So they may make the urine look red, brown, blackish, right? I mean, the patient may come and tell you, hey, my urine, I think I have blood in my urine, right? It's your job as a doctor to decide, okay, is this true hematuria or is this not true hematuria? And so for a lot of the untrue or the false hematurias that I just described, they may show up on dipstick as positive blood, right? 1 plus 2 plus 3 plus blood, because that dipstick, it's really a kind of a dirty test, and it will pick up abnormal coloration in the urine, and it will call it as blood, right? Um, but then when you get microscopy, right, you really spin that urine down and look at the details, you won't see any red blood cells, or you'll see very few red blood cells per high powered field. So when you get that discrepancy where you get, dark colored urine and it says like 3 plus blood on dipstick, but very few red blood cells on microscopy, that's not true hematuria. And you should start thinking about myoglobinuria, hemoglobinuria, indirect bilirubin, porphyria, and other drugs, things along those lines. So now that we understand that hematuria is red blood cells in the urine, we got to decide how we can break it down further. And in order to do that, we just have to understand the physiology of the renal system and the urinary tract. All right. So, really, our urinary tract is beautiful in its job to keep red blood cells out of the urinary tract. So, there's two main pieces there's the glomerular filter, okay, that includes my endothelium, my glomerular basement membrane, and my podocytes. And those are responsible for keeping red blood cells out of the tubular system, the nephron itself, right? Then, as we kind of go throughout the renal pelvis, the bladder, the ureters, the urethra, all the way down to where the urine actually gets excreted, our urinary tract is full of urothelium and other protective cells that should keep red blood cells out of the urinary tract, right? So, really, when you think about it, there's either a problem in the glomerulus or there's a problem elsewhere throughout the urinary tract that is allowing blood in. So, really, at its simplest core, right, we can just think about hematuria as is this a glomerular problem or is it a non-glomerular problem, right? Don't oversimplify or don't overcomplicate it. It's truly that simple. So if we wanted to find something as glomerular or non-glomerular, well, how do we do that? We do that really two ways. We do gross examination and we do urinalysis. Okay. So gross examination, I think about it the exact same way you probably learned about melena and hematochezia uh, for GI bleed, right? Melena is more of a sign of upper GI bleed. Hematochezia is more of a sign of lower GI bleed. Obviously, there's overlap, right? If you have a really rapid upper GI bleed, it can produce hematochezia. And the reason behind that is in upper GI bleed, the blood has more time to kind of be digested, oxidized throughout your blood or throughout your body before you poop it out, and that extra oxidization and metabolism ends up turning the hemoglobin into more met hemoglobin, which will turn this dark tarry type of color, right, and consistency. Whereas hematochezia is a lower GI bleed for the most part, and that blood has less time to travel through the GI tract, so it comes out a brighter red, right? And then obviously, like I said, right, if you have a really rapid upper GI bleed, that can present as hematochezia as well, because that blood is just spending less time through your GI tract. And so it's the same thing with hematuria, is if hematuria is occurring at the level of the nephron, right, at the level of the glomerulus, right, that blood has a lot of time. It's got to travel through the nephron, then the renal pelvis, then the ureter, then the bladder, then the urethra. It's got a lot of time to be oxidized to hemoglobinuria or to met hemoglobin, and it's going to come out like a darker tea-colored, smoky type color for the most part. Whereas if a bleed happens, further down on the renal system, the urinary tract system. So, like, let's say the patient has like urethral trauma during like a motor vehicle accident or for some reason, that blood has a lot less time to travel through the urinary tract, and it's going to come out a brighter pink, red type color, right? So just the color itself, right, a darker tea-colored, smoky color might be more lean me more towards a glomerular source, a brighter red, pink color more towards a non-glomerular source. And then when you think about clots, right, clots are really only going to be present throughout the urinary tract, so non-glomerular source, because you're not going to get clots coming through the glomerulus, right? Those are going to be way too big. So that's like gross examination. Just by looking at the urine, right? Oftentimes the patient will have a urine sample for you, or just asking the patient, what does your urine look like, right? You can easily pull up a chart online and have them just pick out the color, right? If they can't describe it. And then the urinalysis itself is probably going to be the most powerful tool you can use. So if I see red blood cell casts are what occurs when red blood cells make their way through the glomerulus. They kind of conglomerate in the tubular system with this TAM horsefall protein, and they form these casts that can then be seen on microscopy. You might see dysmorphic red blood cells, as these red blood cells are kind of like shaken throughout these really tight tubular systems. And then the specific dysmorphic cell that is very specific for glomerular nephritis is called an acanthocyte, which is a spur cell. Okay, I'll show you a picture of that in a second. The sensitivity is about 50%. So, half the patients with glomerular nephritis have it and half don't. Whereas the specificity is almost 98% for glomerular nephritis. So if you do see acanthocytes, you can be pretty sure that this is likely glomerular nephritis that is causing your hematuria, especially if we take a step back and we're like, okay, the urine was this tea-colored, black-colored, smoky color, right? And I see red blood cell casts. But the most specific thing, according to the literature, is using a urinary albumin to total protein ratio. And if that ratio is greater than 0.59, it's got a 97% sensitivity and essentially 100% specificity. And that should make sense, right? If we're damaging the podocytes along with the endothelium and the glomerular basement membrane, you're going to dump albumin into your tubular system as well. And you're going to dump a significant amount of albumin in the urine compared to some of the other total protein you get that are like those smaller proteins that kind of can sift through your glomerular basement membrane, podocytes, endothelium, things like beta-2 microglobulin, some light chains, things along those lines. But if I really damage my podocytes secondary to an immune attack on my glomerular basement membrane, on my glomerulus, then we can dump albumin in as well. So if you get a urinary albumin and total protein ratio that's greater than 0.49, you can essentially be pretty, like almost 100% sure this is glomerular nephritis. because then in non-glomerular, you're less likely to see any of those. Um, so again, in glomerular bleed, we're likely to see it be more dark, tea-colored urine, and then we're likely to see red blood cell casts, potentially acanthocytes if it is glomerulonephritis, right? There are other things that can cause glomerular bleed, and then a urinary albumin to total protein ratio greater than 0.59 has a very high specificity for glomerular bleed itself. All right. So then when we take a look at our patient's urine that they got in the ED, and I'll let you guys read the labs here and take a look at the urine. So pause your screen, and then I want you to tell me, do you think this is glomerular or non-glomerular? All right. So we see there is 3+ blood, but we have a ton of red blood cells, right? So we're pretty sure this is true hematuria. We see dysmorphic red blood cells. We see red blood cell casts. No bacteria, no epithelial cells, no white blood cells, no crystals. So probably not an infection, right? The leukocyte esterase nitrates are negative. And then our urine albumin to total protein ratio is 240 divided by 300, which would be 80% or 0.80. And then my urine is looking kind of like this tea color. So all of this is definitely pointing me more towards a glomerular source. So again, when you think about your hematuria, is it glomerular? Is it non-glomerular? And then you just kind of go down your pathway of non-glomerular. Just think about all your anatomy, and kind of big things would be infectious and malignancy kind of at every stage. Trauma is another big one to think about as well. But this case is definitely pointing us more towards glomerular. So then we got to decide, okay, is this glomerulonephritis, nephrotic syndrome, thin basement membrane nephropathy, Alport's, exercise, or loin pain hematuria syndrome? Your biggest ones to consider are, of course, going to be glomerulonephritis and nephrotic syndrome are probably going to be the most common things you would come across as an internist or, on the wards. So the ED already got us our red blood cell sample. So now let's look at it under the microscope, and we see a lot of these guys here. So these are what our spur cells look like, right? They look like little spurs. So these are our acanthocytes, and we see quite a few amount of them. And so now we're pretty sure, okay, this source of hematuria is glomerular, and it's likely glomerulonephritis. Remember, acanthocytes had a 98% specificity for glomerulonephritis. So now we're pretty sure we're dealing with a glomerulonephritis, and we haven't even seen the patient yet, right? All I've done is I got a brief bit of information. We confirmed it's true hematuria. We then kind of narrowed it down to, okay, this is likely a glomerular source. And now we've narrowed it down to this is likely glomerulonephritis. So without even seeing the patient, we already know we're dealing with a glomerulonephritis. And then you can ask very specific questions, and you can do a very focused physical exam looking for certain things that might point you one way or the other. All right. So we have it down to glomerulonephritis. Let's ask our patient a few more questions. We learn he's had mild fevers, malaise, small joint arthralgias, and a 10-pound weight loss over the last month and a half. He's had 3 episodes of epistaxis in the last month and 2 bouts of sinusitis. He's had 4 bouts of upper respiratory tract infection and 1 episode of right-sided otitis media in the last 6 months, but he's had none in the last few weeks. He's coughed up a small amount of bright red blood the last 2 days, and then he has a new rash seen bilaterally on his legs and buttocks. And so we'll go through the differential for glomerulonephritis, but if you're already familiar with your differential for glomerulonephritis, you might actually already know kind of what's going on in this patient. But we got this bit of information, and as we're talking to him, we notice some things. We notice we're very observant physicians here, and so we notice, we see this abnormality in his nose, and we ask, hey, has your nose always looked like that? And he tells you, hey, no, like within the last couple of months, my nose started to kind of change shape a little bit. Maybe you even asked to see a driver's license from a couple years ago, and his nose looked completely normal to him back then. And then we also see his rash he was mentioning, and you can see the rash is palpable on exam. We also get a low-grade temperature. He's almost tachycardic. His respiratory rate's elevated. His SpO2 is a little bit low on room air. We hear crackles bilaterally in the bases. He's got some joint stiffness, crusted blood found in his nose, and then no murmurs, rubs, or gallops. So just off of seeing this patient and doing a quick history and physical exam, if you know your differential for glomerulonephritis, you probably already know what this is, right? I've done a very hypothesis-driven exam so far. I already know what labs I want to order. But to kind of flesh out our system, right, we got to think about what is the differential for glomerulonephritis. And it's really simple, right? It's four main categories. We think about my oncopositive glomerulonephritis, my anti-glomerular basement membrane glomerulonephritis, my low complement glomerulonephritis, and then kind of my other category. Um, so think about like kind of fill in those boxes for me. So what would be some examples of oncopositive, anti-GBM positive, low complement, and then are there any other causes you could think of? So your oncopositive are of course going to be your GPA and then EGPA and MPA, right? Your GPA is going to be C-onca and proteinase 3 positive. Your MPA and EGPA tend to be more MPO positive, P-onca positive. Your anti-glomerular basement membrane would be our Goodpasture syndrome, right? That's an autoantibody destruction of type 4 collagen in the kidneys and your lungs or the capillaries. Your low complement, in order to get low complement like that, we classically need to have immune complex formation that activates and deposits the complement. So think about what are some major immune activative like immune complex situations, right? The big ones that come to mind are going to be post-streptococcal glomerulonephritis, lupus, infective endocarditis, cryoglobulinemia, things along those lines, right? There's a few more we can discuss as well, but those are going to be, some of the major ones you're going to want to think about. And then kind of my other category would be things like IgA nephropathy and Henoch-Sloan purpura. Um, so we go to our differential, right? And there it is, right? So we already know what we need to order, right? Just based off of my differential for nephritic syndrome and glomerulonephritis, right? Which we kind of narrowed it down to. We should order our ANCAs. We should order anti-GBM. We should order complement. And then with every patient, right, you'll get a CBC. And this patient, I would probably get a BMP or a CMP, of course. And then there's a few other things we want to order, things like your hepatitis B and C would for sure be useful. If we're considering a diagnosis of lupus, getting an ANA, anti-double-stranded DNA, anti-Smith, things along those lines, anti-phospholipid antibodies. But just knowing this framework already guides your next diagnosis, or your next step in management. And then really to make that definitive diagnosis of glomerulonephritis, we often will do a kidney biopsy. Sometimes we don't need to, but the kidney biopsy would be definitive. Okay, what's going on here? So we get the labs and we see he's got a little bit of leukocytosis. He's got a normocytic anemia with a low reticulocyte production index, and then an elevated platelets, right? So his leukocytosis likely secondary to an underlying inflammatory process. His normocytic anemia, that's hypoproliferative, likely secondary to anemia of inflammation. And then his platelets being elevated, likely reflecting reactive thrombocytosis. Remember, the three big things that can cause thrombocytosis are reactive thrombocytosis, secondary to inflammation, iron deficiency anemia, and then myeloproliferative disorders, things like polycythemia rubra vera and essential thrombocythemia. We see on his BMP, his potassium's a little bit elevated, bicarb low, BUN and creatinine are elevated, right? Likely secondary to his extreme kidney inflammation and kidney damage. And then we see his ESR and CRP are elevated. We know it's an inflammatory process. His PR3 ANCA and C-ANCA are quite elevated. MPO, anti-GBM, C3, C4, all normal. Hepatitis B and C, not revealing. And then the kidney biopsy shows post-immune necrotizing glomerulonephritis, which helps fully diagnose our condition. We got a chest x-ray and BAL because there was concern for pulmonary renal syndrome since he had hemoptysis and crackles in his lungs. For more information on that, I have a whole video on pulmonary renal syndrome. But this patient, we saw no diffuse alveolar hemorrhage, so not concerned at that time. So now just based off of this, do you guys know what disease this patient has? If you need a second, pause your screen and kind of consider, and then I'll move on. So everything is pointing to a C-ANCA positive. This would be GPA, okay, would be our definitive diagnosis here. And then here's all the other diseases that I kind of mentioned to consider when you're working up a patient for glomerulonephritis. Remember, we got to glomerulonephritis. We confirmed true hematuria. It was dark tea colored. We saw that there were red blood cell casts. We saw that there was an elevated urinary albumin to total protein ratio. It was like 0.8. So those all pointed me towards a glomerular cause. We saw acanthocytes, which are very specific for glomerulonephritis. And then as we walked into the patient's room, we saw a saddle nose deformity. He had the history of upper respiratory tract, lower respiratory tract, and kidney dysfunction, all very concerning for GPA. He also had the palpable purpura that points me more towards a small vessel vasculitis, as these small vessel vasculitis impact and cause inflammation of these small dermal capillaries and small dermal vessels. It causes extravasation of red blood cells and extravasation of the blood kind of to the surface of my skin, to the epidermis. And all this inflammation, those fibrin, macrophages, things like that, kind of give a little tint to, or like a raise to that purpura, and so it becomes palpable, right? It's palpable purpura. Point me towards a small vessel vasculitis, and small vessel vasculitis really can be differentiated into oncopositive and onconegative, right? And in this case, the oncas came back positive for the C-onca pattern with proteinase 3 positive, and our kidney biopsy showed pauci-immune necrotizing glomerulonephritis, which is classic for our onca-positive, rapidly progressive glomerulonephritis causes. So we have now diagnosed GPA. We did it based on this hypothesis-driven method. What is GPA? I've talked about it in many of my videos, but it's a small or medium vessel necrotizing vasculitis. It'll have granulomas formations, right? We can see that on histology. And then it's pauci-immune crescenteric glomerulonephritis. That just means that you're going to get inflammation of the glomerulus, right? But it's going to be pauci-immune, meaning that it's not true immune complex formations as things such as like our low C3 and C4 would cause. Classically, middle-aged men, you usually get upper respiratory tract, so sinusitis, otitis media, epistaxis, crusting. You get lower respiratory tract inflammation, so you get nodules, cavitations, hemoptysis, and alveolar hemorrhage. And then we get kidney damage. We can get rapidly progressive glomerulonephritis. We can see crescents formed when we do a biopsy. Lab pattern, classically PR3 onca or PR3 antibody positive. That'll be a C-onca pattern on immunofluorescence. So the C-onca meaning the cytoplasm of the neutrophils will light up when we do immunofluorescence. Your anti-GBM should be negative. The complement is usually normal. Treatment, we do steroids plus an induction agent, something like rituximab or cyclophosphamide. And then here is side effects. We're not going to go into detail for that. This was more just how to work up hematuria. And then just for your information, again, the positive likelihood ratios for seeing your dysmorphic red blood cells, especially your acanthocytes, pretty good, 5.5. And then that urine albumin total protein ratio for glomerular disease is essentially infinity, right? So if you see an elevation of the urine albumin protein ratio greater than 0.59, you can be pretty sure this is a glomerular source. So there you have it, right? We worked up a pay, like hematuria is a tough one, right? Like, because a lot of students are like, well, if it's not a UTI and it's not bladder cancer or renal cancer, I don't even know, right? We worked up this patient with hematuria. We essentially made our diagnosis, or we at least knew it was glomerulonephritis without even seeing the patient, right? Then you go in knowing it's glomerulonephritis. You know I got to think about onca, anti-GBM, C3, C4, and other, and we can get at just a few questions, a few physical exam findings that might push me one way or the other. And that's pretty much how you do it, right? So you should have this kind of framework in your head for almost all the chief complaints, right? And it truly guides your next steps. So hopefully you like this. I'll try to put out some more videos like this. Reach out with any questions. See you next time.